Hello, everyone. Good morning, good afternoon, and good evening everywhere. Thank you so much for joining us today. We are so pleased to welcome our senior nurse practitioner from multiple myeloma and plasma cell group at Vanderbilt University Medical Center. Shelton Harrell is with our program even before I joined the Vanderbilt, and I learned a lot from her experience working along the side in the transplant division and myeloma clinic. She is at forefront of novel therapies in multiple myeloma. She's a part of our phase 1 team also. So she does see patients who are undergoing novel therapies for plasma cell malignancies, including bispecific antibodies. Our institute was part of the early wave of clinical trial involving bispecific. So she's been doing bispecific therapies for various hematological malignancy, mainly multiple myeloma, for over almost 2.5, 3 years, right? We are lucky to have her. And today she will go over the acute side effects of bispecific, mainly focusing on the plasma cell malignancies. And Shelton, floor is yours.
Thank you so much, Dr. Laurie, for that kind introduction. Like he said, I am Shelton Harrell, and I am a nurse practitioner at Vanderbilt in the outpatient clinic. And I primarily focus on multiple myeloma. So today we're going to talk about the acute and late toxicities of bispecific antibody therapy in patients with multiple myeloma. So these are my disclosures. Our objectives today are to briefly discuss bispecific antibody therapy in patients with relapsed refractory multiple myeloma. I'm going to provide an overview of the potential toxicities associated with this treatment modality. I'm going to highlight the importance of recognizing, managing, and monitoring these toxicities. So multiple myeloma is a type of cancer that affects plasma cells, which is a type of white blood cell found in the bone marrow. In multiple myeloma, these plasma cells become cancerous and multiply uncontrollably, crowding out healthy blood cells in the bone marrow. This can lead to a variety of symptoms such as bone pain, weakness, fatigue, frequent infections, and anemia. Multiple myeloma is considered a treatable but incurable disease with treatment options including chemotherapy, targeted therapy, immunotherapy, and stem cell transplantation. So bispecific T-cell engagers, or BiTEs, are a specific type of antibody therapy. It's a type of immunotherapy that has emerged as a therapeutic approach to treat multiple myeloma. Bispecific antibodies are designed to simultaneously target two different proteins, allowing for precise and targeted therapy. This presentation will focus on the role of BiTEs in myeloma and with the acute and late toxicities seen with this treatment approach. So BiTEs can be designed to target both a protein on the surface of the cancer cell and a protein on the immune cells. B-cell maturation antigen and G protein coupled receptor GPRC5D are proteins that are highly expressed on the surface of myeloma cells, making it an attractive target for therapy. CD3, on the other hand, is a protein found on the surface of T cells, which are a type of immune cell involved in recognizing and eliminating abnormal cells in the body. This dual targeting mechanism enhances the immune system's ability to recognize and attach to cancer cells. In myeloma, BiTEs are designed to do two important things at the same time. First, they attach themselves to a specific protein on the surface of the myeloma cells. And secondly, they also attach themselves to another protein on immune cells that help the body fight off infections and diseases. By doing this, the bispecific antibodies bring the immune cells closer to the myeloma cells, almost like guiding them, and this is called immunologic synapse. So this helps the immune cells recognize and attack the myeloma cells more effectively. When the immune cells attack the myeloma cells, it helps to efficiently rid the body of these cells and lead to durable responses. The goal of these treatments are to enhance the body's immune response against multiple myeloma and potentially improve outcomes for patients with relapsed refractory disease. They come in a variety of different sizes and shapes, and every company has a different way they've engineered these antibodies. Some of them bind to CD3 on a low level, and so it only mildly activates the T cell, and some bind with full strength to activate the T cells. So if you activate the T cells too much, you increase the side effect profile. You activate them too little, and you might not get as good of a response. Once we bind the T cell and the T cell becomes active, that's when people notice the side effects. So I'm going to focus on the FDA-approved bites listed here, and for the sake of brevity. So we're going to look at teclistamab and elranatamab target BCMA and CD3, while tequetamab targets GPRC5D. So first, we're going to go over the acute toxicities. The acute toxicities with bites refer to the immediate or short-term adverse effects that can occur shortly after the administration of therapy, usually during the step-up dosing period or within the first month. The most common are cytokine release syndrome and or CRS, as well as neurotoxicity, including immune effector cell-associated neurotoxicity syndrome, or ICANS for short. So in here we have the 3 different drugs we're talking about, and the studies are looking at phase 1 and 2, and most of them. I have the target that they all have listed here. CRS, you'll see that more than half of patients do develop some grade of CRS, but as you can see, grade 3 plus CRS is a lot less with these drugs, especially compared to CAR T. Neurotoxicity is also seen in more than half of patients, but again, grade 3 plus, the more severe neurotoxicity, it's usually less than 10% in these patients, which is great because sometimes it's a lot more in CAR T. So the first toxicity I'd like to discuss is CRS. So cytokine release is when you have a rapid, large release of cytokines, and it causes a cluster of symptoms, and the hallmark symptom for cytokine release syndrome is CRS. But then that can progress to maybe more severe symptoms such as low blood pressure, rapid heart rate, shortness of breath, or difficulty breathing. With bispecifics, we're seeing mild cases, and patients will often present with fever. So we want to try to mitigate the effects of CRS, and typically how we're doing this is by starting patients off with a lower dose and gradually increasing that dose every 48 to 72 hours until we can reach that target dose. We're also administering pre-medications prior to dosing of bites with an antipyretic or acetaminophen, an antihistamine, diphenhydramine, and a steroid, dexamethasone, to mitigate CRS. It is also important to obtain baseline inflammatory markers prior to dosing so we can trend inflammation after dosing to guide our management. I'll discuss the specific labs in the next slide, though. Baseline echo is not required, but should be performed as clinically indicated. Bispecifics do not cause direct cardiotoxicity, but a baseline cardiac evaluation may be helpful to understand a patient's baseline cardiac reserve and the ability to withstand CRS-related hemodynamic changes. In this sense, development of grade 1 CRS in patients with known cardiac comorbidities may prompt more aggressive management to avoid development of hemodynamic instability that can be seen with higher grade CRS. As a clinician, we must know how to spot the early signs of CRS so we can effectively manage it and improve outcomes. So symptoms can be progressive, but usually must include fever at the onset and may include hypotension, capillary leak, or hypoxia, and high end organ dysfunction. So this picture provides a visualization of the symptoms associated with CRS according to the body system. Currently, my institution is hospitalizing patients for 48 hours after each step-up dose and treatment dose of bite therapy, so roughly about 9 to 10 days at the start, depending on the drug. This allows us to monitor patients daily for CRS and other common acute toxicities like neurological deficits, pancytopenia, and hepatotoxicity. There are noticeable changes in various laboratory measurements during CRS. While cytokine abnormalities have been well documented, this data is not readily available in a lot of academic centers within a useful time frame for determining the severity and planning the management of CRS in patients because they take too long to result. CRP, or C-reactive protein, is a commonly used and cost-effective laboratory test that initially appeared to be a promising biomarker for CRS, but CRP is not specific to CRS. There are multiple ways to measure it, and the ASTCT data suggests that changes in CRP levels are delayed compared to clinical changes, typically by at least 12 hours. So due to these limitations, ASTCT excluded the use of laboratory parameters in the definition and grading of CRS and instead rely on clinical observation. However, they do recommend the continued measurement of cytokines, CRP, ferritin, and other parameters to gather additional data for future research purposes and to help guide you in management. At Vanderbilt, we obtained baseline CBC with differential, CMP, CRP, ferritin, and LDH. These labs are also obtained daily at a minimum during hospitalization step-up dosing to monitor the trend, as they can help guide our clinical decision-making once a patient develops CRS. So how do we grade CRS once it occurs? Initially, there were numerous grading systems to determine the severity of CRS, which made it difficult to compare the safety of different products that hindered the ability, and it hindered the ability to develop optimal strategies for toxicity management. And some aspects of these grading systems made it challenging to implement across centers. So to harmonize the definitions and grading systems for CRS and neurotoxicity, experts came together in June 2018 at ASTCT to develop these guidelines, and this was published in 2019. So as stated in the previous slide, ASTCT excluded the use of laboratory parameters in the definition and grading of CRS and instead rely on clinical observation. So with grade 1, of course, you're going to have a fever, temperature greater than or equal to 38 degrees Celsius. You're not going to see hypotension or hypoxia usually in this. Grade 2, of course, you're going to have that fever, and you could see hypotension and hypoxia, or you will see those, but at this point, they're not requiring vasopressors, and they're only really using low flow oxygen if they need it. Grade 3, you're going to have, of course, that fever, and you're definitely going to have hypotension, and they're requiring a vasopressor with or without vasopressin. And you're also requiring high flow or you could be requiring high flow nasal cannula, face mask, non-rebreather mask, or venturi mask for that hypoxia. Grade 4, you're still going to have that fever and the hypotension and the hypoxia usually, but you're requiring multiple vasopressors at this point, and you're requiring positive pressure for that hypoxia. So you've identified CRS in your patient, and thanks to ASTCT grading system, you know what grade of CRS they have. Now, how do you manage it? So management varies based on institution, but at Vanderbilt, we use this SOP, which was initially developed for CRS and CAR-T patients. And it can vary based on the drug, but it generally follows this. So for grade 1, they only have a fever without hypotension. You're going to use IV fluids, antipyretics, and symptomatic management of constitutional symptoms. But I do want to point out that if a patient is coming in with a fever, you also really want to rule out possible infectious causes. So we are doing the baseline fever workup of blood cultures, respiratory panel, UAN culture, chest x-ray, to double check they don't have an underlying infectious component. You can consider tocilizumab with rare exceptions like patients that are elderly or frail, or patients with significant comorbidities that really will not tolerate a sustained fever. I want to quickly explain what tocilizumab is, since it's a mainstay drug in treating CRS. Toci is a humanized monoclonal antibody that targets IL-6 receptor and binds to it. So this binding prevents IL-6 from binding and increasing inflammation. We give pre-meds of acetaminophen and diphenhydramine before giving. When a patient responds, they usually respond quickly, and we typically see hypoxia and hypotension resolve within 5 to 7 days, but it can be a lot faster. Early use can reduce the rate of CRS without affecting, T-cell expansion, which makes it an attractive candidate. It's very expensive, though, and there have been drug shortages in the past, which is why we don't typically use it up front. There are studies that are showing this, but we don't do that routinely. Management for grade 2 CRS is continuing that supportive care and adding cardiac monitoring to keep a closer eye on them. You may need to add vasopressors if they do not respond to IV fluids. You can also add supplemental oxygen if they need it. Grade 2 is when we add that tocilizumab, definitely. And you want to make sure you're working with your pharmacy partners to ensure that the dosing is readily available. Patients with grade 3 CRS are most likely to be transferred to the ICU so they can receive that vasopressor support. You're going to continue tocilizumab per grade 2 and add steroids. If they start to improve, we like to taper those steroids quickly, but if they don't improve, then we're escalating to grade 4 management. Patients with grade 4 CRS, of course, will definitely be in the ICU. You want to make sure they have a protected airway. They may require dialysis if they're experiencing end organ damage. At this point, the steroids will be increased and you will continue the TOCI per grade 2. If they don't improve after these measures, we start looking at alternate immunosuppression like anakinra or methotrexate. Another early side effect we can see from BITE therapy is ICANS. ICANS are immune effector cell-associated neurotoxicity syndrome, specifically refers to neurotoxicity associated with the use of certain immune cell therapies, such as CAR T therapy or BITE therapy. ICANS can manifest as really any neurologic symptom. Most common ones include difficulty speaking, tremor, confusion, and even coma. These can become more severe if not treated, so we really monitor for them by using the ICE score. Thankfully, ICANS typically occurs in less than 10% of patients receiving BITE therapy and usually occurs within the first few weeks of therapy initiation. So some common neurological symptoms associated with ICANS include confusion. The patients may experience a state of mental disorientation, difficulty concentrating, and problems with memory or attention. They can have agitation, so they're restless, irritable, and a state of increased motor activity can also be observed with ICANS. Delirium is another one. It's kind of looks like a state of acute confusion and changes in consciousness characterized by disorientation, hallucinations, and fluctuating levels of alertness. ICANS can also cause abnormal electrical activity in the brain, leading to seizures. Difficulty with speech and language production or aphasia and comprehension may occur in some cases of ICANS. Expressive aphasia appears to be a very specific symptom of ICANS and can start as impaired naming of objects, paraphasic errors, hesitant speech, and verbal preservation, and may progress to global aphasia, which is characterized by expressive and receptive difficulty. Patients with global aphasia may appear wide awake, but are mute and unable to follow commands. So they also are going to experience some motor abnormalities. Patients could have weakness, paralysis, abnormal movements, or difficulty with coordination and balance. It's important to note that the severity and specific symptoms can vary among individuals and may depend on the underlying cause, immunotherapy treatment, and individual patient factors. So early recognition and prompt management of these symptoms are crucial in the optimal care of patients with ICANS. And also knowing what they look like at baseline, that's extremely helpful too. So like CRS, ICANS has gone through a number of reiterations and grading systems. So when ASTCT came together to develop the CRS grading system, they also developed one for ICANS called the ICANS grading system. This grading system incorporates the ICE score, the patient's level of consciousness, occurrence of seizures, and motor findings, and signs of ICP to produce a concise, all-encompassing grading system. So we'll look at the grading system in the next slide, but first I want to go over the ICE scoring system. ICE stands for Immune Effector Cell Associated Encephalopathy and assesses multiple neurologic domains that span the constellation of signs and symptoms associated with the neurotoxicity. It incorporates key elements of the mini-mental status examination to evaluate the alterations in speech, orientation, handwriting, and concentration that are highly suggestive of the encephalopathy observed in patients with ICANS. It's an important tool for those of us to use at the bedside. You'll need to perform this prior to initiation of treatment to obtain a baseline and prior to any step-up doses of therapy and daily, sometimes twice daily, inpatient. This is performed every 4 hours if the score drops below 10. So as you can see, we're asking basic neuro exam questions and having them count backwards and writing a sentence, then scoring it. A patient who can perform every parameter scores a 10 out of 10. So once we have the ICE score, we plug it into the grading system seen here. A patient with grade 1 ICANS may have a delay in response or disorientation to time or place, mild inattention with difficulty in counting numbers backwards, or impaired handwriting. There may be drowsiness, but the patient awakens spontaneously, and when prompted, the patient should be able to complete most of the ICE assessment. Grade 1 ICANS may be seen during CRS, waxing and waning with febrile episodes. Patients with grade 2 ICANS often have some expressive aphasia, limiting the ability to communicate spontaneously. Patients may often have difficulty writing a standard sentence due to poor handwriting and apraxia. They have difficulty naming objects due to expressive aphasia and are following commands due to the receptive aphasia and poor concentration. In our experience, expressive aphasia is the most specific first sign of severe neurotoxicity, and early signs in grade 2 include paraphasic errors, or the production of unintended syllables and words during attempts to speak, as well as verbal preservation, like repeating the same words over and over. Patients with grade 2 ICANS are able to communicate their needs with effort. Patients may have a depressed level of consciousness, but are arousable to voice, and the responses may be slowed. Patients with grade 3 ICANS have severe global aphasia and do not speak or follow commands even when wide awake, and thus may be unable to answer any of the ICE questions. Alternatively, they may have excessive drowsiness and need tactile stimulus to attend to the examiner. Any clinical seizure, whether simple, partial, complex, partial, or generalized, and any electrographic seizures would also meet criteria for grade 3 ICANS. ASTCT defines grade 4 ICANS as patients who have a score of 0 on the ICE assessment because they're unarousable and unable to perform the ICE assessment. Stupor and coma may be seen. This depressed level of consciousness should be attributable to no other cause, like make sure they don't have a sedating medication that's causing it, which is often a complicating factor in sick patients with CRS as well. Some patients may require intubation for airway protection. In addition, any patient experiencing prolonged or repetitive clinical or subclinical electrographic seizures without a return to baseline in between, or with deep focal motor weakness such as hemiparesis or paraparesis, would be considered to have a grade 4 ICANS. So how do we manage ICANS? Management is very similar to CRS management in that we're going to give them supportive medications, use TOCI if concurrent CRS, and give steroids. With grade 1, you're doing supportive care and considering adding prophylactic, non-sedating, anti-epileptic medications like Keppra. You're going to reorient the patient, institute fall precautions, raise the head of bed by 30 degrees to prevent aspiration. You can administer TOCI if they have concurrent CRS, and you can consider adding IV Dex. With grade 2, you'll continue supportive care and consult neurology. You may do that before then, but that's what we're looking at here. We're ordering brain MRI, LP, EEG, and starting anti-epileptics if the seizures are present. You'll give TOCI if CRS is present also. If not present, you'll start Dex 10 milligrams every 6 hours. If they don't improve, then you manage as grade 3. So grade 3 ICANS, you're going to transfer to the ICU. They're not there already. You're going to manage CRS if they have it and give Dex, of course. If not improving, then they are managed as grade 4, and they are usually placed on mechanical ventilation at this point to protect their airway. The steroids are changed to high-dose methylpred, and we're giving 1,000 milligrams a day IV for 3 days. If they do not improve, we can consider alternate forms of immunosuppression. So I'd like to quickly touch on some toxicities that are specific to talquetamab, which targets the GPRC5D receptor on the myeloma cell, so not BCMA-directed therapy. We do see skin peeling with the hands and feet. This is typically or usually painless. We can manage with barrier creams or ammonia lactate. Patients do quite well with these lotions. Patients will also often present with brittle peeling nails. So for this, we're recommending over-the-counter nail lacquer to harden it, or vitamin E oil, which can be helpful. Then the other oral toxicities that we see with talquetamab, the other toxicities are oral. So altered taste, a dry mouth, difficulty swallowing, and this can lead to patients not wanting to eat. So there may be associated weight loss. So we tried to manage this with either saliva substitute, sprays, or rinses, but sometimes patients will need a dose hold or a dose reduction. So we're now going to look at the toxicities that occur after step-up dosing of therapy. It is roughly a month after initiation of a bispecific. We're going to focus on the most common toxicities, including infections, cytopenias, and hypogammaglobulinemia. There are others documented, but these are the most common. I also want to keep in mind that a patient with relapsed refractory myeloma has seen several lines of therapy and often starts BiTE therapy with hypogam and being cytopenic, so that must be taken into account as well. Infections are an important complication of bispecific antibodies, in particular, the bispecific antibodies that target BCMA. So the Reynolds group performed a systematic review and meta-analysis of infections and published studies of patients with myeloma treated with bispecific antibodies. The pooled prevalence of all grade infections was 56%, whereas the prevalence of grade 3 or greater infections was 24%. Patients who were treated with BCMA-targeted bispecifics had significantly higher rates of grade 3+ infections than non-BCMA bispecifics, so 25% versus 20%. So why are patients on bispecifics at high risk for infection? Well, bispecifics are designed to hook on to myeloma cells to destroy those cells, but there's, of course, some friendly fire. This means that patients' normal plasma cells can be depleted, resulting in less immunoglobulin production. So furthermore, white blood cell production and maturation can be impaired. And thirdly, T cells play a key role in immunity, and as they are engaged to destroy myeloma cells, regular T cell function may also be dampened. All of these effects put patients at risk of infection. Whereas with CAR T, only one infusion is given with BiTEs, patients undergo ongoing treatment with bispecifics as often as weekly. So for this reason, side effects from treatment may also be prolonged. So how do we prevent it? Practices will vary according to institutions, but most will start patients on the following prophylaxis regimen. So you're going to want to cover PJP prophylaxis with Bactrim, Dapsone, Topiquone. PJP pneumonia can be a serious risk for these patients. So we really want to reduce that risk by placing them on these medications up front. There's also a risk for several viral infections like shingles while on BiTEs. So an antiviral medication like valacyclovir is prescribed. It is not unusual for patients undergoing BiTE therapy to become neutropenic. So we typically prescribe these prophylactically with Levaquin or Ceftonir once treatment is initiated to mitigate the risk of bacterial infections. We also start IVIG if IgG levels are less than 400 to prevent infection, but more on this in the next slide. While the duration of prophylaxis is not established, some members of panel recommend continuing prophylaxis for up to 6 months following treatment discontinuation. In patients with a history of latent hepatitis B, specific antiviral therapy is recommended as it is with other CD20-directed therapies. Although vaccine response may be impaired in patients receiving bispecifics, experts also recommend that patients receive standard vaccinations, not live vaccines, but the others, and including those against influenza and COVID-19, if indicated. So many patients with myeloma develop hypogammaglobulinemia during their disease. This is attributed to immunoparesis in patients with non-IgG myeloma, exposure to numerous lines of therapy, and older age of diagnosis. Bispecific antibody therapy to cause hypogammaglobulinemia, although the incidence and severity may vary depending on the specific therapy and the individual patient factors. The development of hypogam in this context can be attributed to a few potential reasons. So the targeting of B cells, bispecifics may be designed to target B cells, which are responsible for producing immunoglobulins. By binding to and eliminating these B cells, the therapy can inadvertently reduce the production of antibodies, leading to a decrease in immunoglobulin levels and subsequent hypogammaglobulinemia. So bispecific therapy can also modulate the immune system by activating or suppressing certain immune cells or pathways. So this modulation can disrupt the normal balance of immune functions, including antibody production. The therapy leads to a suppressed immune response or interferes with the normal functioning of B cells. It can, of course, result in decreased immunoglobulin levels and hypogam. So, and bispecific antibodies are also, because they bind to specific targets, but there is the possibility of off-target effects. If the therapy inadvertently targets and eliminates non-specific B cells or interferes with the normal functioning of B cells, it can impact immunoglobulin production as well. Cytopenias can be, oh wait, I think I forgot. So the way we intervene is we monitor IgG levels at least monthly. And we're going to start IVIG 10 grams monthly if the IgG level is below or at 400, or prophylactically, honestly, once you start bispecifics, if the insurance allows it. Some will allow it if they are below 500. So a study at Mount Sinai found a rate of grade 3 to 5 infections in 80% patients lower on IVIG. I'm sorry, IVIG may be more useful now also due to the high presence of COVID-19 antibodies in the donor pool, so it'll help protect against that if possible. So cytopenias can be another delayed toxicity of bispecifics, and this can be caused by a multitude of factors. The myeloma disease state can cause cytopenias in and of itself, depending on the disease burden and the crowding out of healthy cell production within the bone marrow. Prolonged cytopenias from prior lines of therapy, especially stem cell transplant, is also to blame. Also, the need for continuous therapy with bites can lead to worsening cytopenias since you are not giving just one infusion like CAR T. So how do we manage this? You're going to want to monitor a CBC with differential prior to all infusions or injections as indicated. You also want to rule out other potential causes of cytopenias with nutrition labs like iron studies, B12, folate, copper, zinc, and manage accordingly. You can employ GCSF and thrombopoietin receptor agonist and give transfusion support if indicated. You may need to reduce the dose or frequency of the therapy according to the package insert. You can also do another bone marrow evaluation to take a closer look and rule out worsening disease or secondary malignancy. So in conclusion, bispecific drugs are here to stay, and they are generating unprecedented response rates. The common acute toxicities are CRS and ICANS. Infections, hypogam, and cytopenias are common in late toxicities, but can also occur even in the first month of therapy initiation. It's important to be able to recognize and manage both acute and late toxicities associated with these therapies in order to adequately care for these patients. And it's important to continue further research and collaboration in this field as we use these drugs more. And these are my references. And thank you so much for having me. That
was absolutely wonderful, Shelton. it was very comprehensive and kind of covered the key aspects of the bispecific therapy. As you correctly alluded, these are totally new class of drugs for our patients, and we are seeing unprecedented responses in patients with triple class or pentaclass refractory myeloma. You and I share a few patients who had a prior CAR T cell therapy and had a disease refractory to it, and still these bispecific therapies were able to get patients into remission. So no questions about the efficacy of these therapies, but as you went over, there are some short-term and long-term side effects. So I want to start with a few questions while we wait for some of the questions from our audience members. We have close to 60 people listening live. This is actually probably one of our most attended seminar. I think the outpatient CAR T had the similar number of participants. So I'm glad to have everybody here on board. So feel free to send your questions. Again, everybody's healthcare setting is different. The resources are different from where you're practicing. So do not hesitate to send any questions. I think we will do our best to kind of go through all the questions. So I'll start with some of the common one, which I always struggle in my practice, Shelton, is the GI side effects of talquetamab. And you have fair share of these patients where they have this loss of taste and smell, and they keep losing weight. So how would you monitor this patient's nutritional status, and at what point, first of all, are there any pharmacological intervention which you have found helpful for these patients? And at what point you say, okay, it's time to hold the drug now? And have you found that helpful in your patient?
Yes, so I mean, obviously, we're going to monitor their weight every time they come in. I'm going to have them keep a food log, similar to what we do in transplant, so that I can view it. I'm going to bring in our nutrition experts so that they can have a call with the patient to see where we can get in some high protein, high calorie foods. If those things don't work, then I often really like to use mirtazapine, usually at 7.5 milligrams at bedtime,
So very
because
low dose, yeah.
Start with that and see, because it's not great at helping with depression or anxiety, well, compared to the other ones in that drug class. But it does cause them to want to eat. So side effect of that drug. And it can also help them sleep, which a lot of these patients are anxious. So it does help with that. And you can increase the dose as tolerated. I did work in supportive care for cancer patients before joining the malignant hematology group. And I did find that the higher doses didn't really help as much with increasing their weight. It did make them more tired, so you could do that. But the lower doses tend to work okay. You can also, I don't love Megace, but you can look at doing Megace or Marinol as well if you want to. Of course, if those things don't help and there's been a profound weight loss, then we're going to hold that drug. And hopefully at that point, because we do see that later, that they've had a good response. So I base it on, their response to the therapy as well. And most of the time when they have weight loss, they have other issues too, like their counts are probably low or their nails are coming off. And so you're wanting to hold it for other reasons too. But once their weight starts to come back, you can usually add it back.
Yeah. No, we had to do this you probably have seen many of these are phase 1 patients where they had, we had to put them on extended hold period. One patient, I remember, she was on hold for almost 6 months before she was able to gain the weight back up. And we had to do even the artificial nutrition through the tube feeding because she was just so malnourished early on after the talquetamab treatment. Unfortunately, with the dose adjustment, so we cut down her dose twice and reduced the frequency of administration from weekly to bi-weekly to monthly, and that certainly helped. But I think more prospective data needs to be collected to kind of better understand, because this is a new class of drug, GPRC5D directing bispecific, and we have a lot of experience managing the cytopenia and CRS and infection from the transplant CAR T world, but this is a totally different set of side effects. So I'd love to hear any questions if audience members have any. So we have a question here from an attendee about once the patient, the question is about CAR T therapy, but I guess we can answer both. Once the patients are discharged after the initial monitoring inpatient, how often they are seen. So if you can answer a little bit about maybe about how we manage our CAR T patient after initial phase of cytopenia and neurotoxicity. And also I want to hear maybe a little bit more about the inpatient, outpatient transition of patient receiving bispecific antibody for multiple myeloma.
So for CAR T, I'm not as well versed in that. I know that they go to, for the first 30 days, I believe they're in the OTU. And so, so they're seen daily. And then I think after that, they go to the long-term follow-up.
Yes.
And they're usually seen, I think, at least every other week for
So,
CAR T.
I can help you with that.
Yeah,
So
with that one.
we
I
are
can help with the
totally
bispecific.
outpatient CAR T program at our center. So we almost never admit a CAR T recipient at Vanderbilt or at a VA hospital where I practice also. We only admit a CAR T recipient if they have any CRS, grade 2 CRS or more, or any neurotoxicity or any other complications. But they're seen daily for the first 10 to 14 days, and then we see them 3 times a week. And then once after a month from CAR T, we transition them to our long-term IEC clinic, and that's where we see them anywhere from once a month to once every 3 to 4 months, depending on where they are and how much support they're requiring. What about bispecific, like how we are doing that for different bispecifics?
Bispecific, depending on the drug, they're usually in there for 10, they're admitted for 10 days at this point in time. We did do 5 patients outpatient and only admitted if they had CRS because we wanted to look at that up front. But then we changed to the inpatient model. So once they have their step-up dosing and they're on the treatment dose, which is usually about 10 days, and they have no CRS or ICANS, anything like that, then they are discharged to follow up with us weekly at least before the next dosing, because they're with teclistamab, you're giving it weekly. And so we see them at least for the first month they're out of the hospital. I typically keep them, I see them every week for the first 2 cycles at least, just to make sure. And just monitoring them. Then if they have, cytopenias or anything like that, then which we do see that may require dose delays, we may bring them back twice a week, depending on what their side effects are. But usually they're tolerated pretty well once you get them through that initial step up period. And you can see them weekly. And a lot of times we're actually, we try to find a community center that can give the dosing, because we have patients that drive from a long way to come, and coming weekly, having to drive 3 hours is a lot on a patient. And so more and more community practices are becoming REMS authorized to give these drugs, and they can do it very safely. We work really closely with our community colleagues and let them know, what to monitor for, what they need to make sure, for infection prophylaxis, and they call us, or they call me pretty frequently if they have any questions. So it works well.
Yeah, so 2 follow-up questions actually came to mind. So number 1 is the frequency of dosing. So I know at our practice, we have kind of played around with bi-weekly or monthly, or on a trial, at least we are doing now every 3 monthly dosing. Of course, that's on a trial. But in your practice, Shelton, I would love to hear, like, at what point you start thinking seriously about de-escalating the frequency of the talquetamab or teclistamab. Of course, this is only for patients who are responding very well to their disease. Of course, we're not talking about patients with active myeloma, but once they are, like, after cycle 4, cycle 6, in complete remission, Would you change this frequency of them? And like, if you do, how would you approach it?
So a lot of times, even if they're not in a CR, but they're, having cytopenias necessitating that you have to hold it, we're finding that changing it to every other week or I have a few on monthly now, and it's still keeping the disease well controlled. So we're basing that, on how well they're tolerating it. As well as, how their disease is responding. But, we've been able to de-escalate the frequency pretty quickly I've had some after cycle 1. We've been able to decrease the frequency of teclistamab at least to every other week. And then once they get in, if they're in, at least a PR or VGPR, doing the every other week regardless. And then so they're a CR doing monthly. And of course we share one patient where she got, I think, one cycle and just did not tolerate well due to infections and everything else. So she's been on hold for, what is it, 3 months now, and her disease
Over
is
three
still
months
doing
now.
well.
Yeah.
Yeah.
And that's something else I want to share with the audience members here, that typically we don't say myeloma is a curable disease, and the traditional treatments like, immunomodulated drug, proteasome inhibitor, or anti-CD38 monoclonal antibodies, we continue these drugs till they have either progression of the disease or they have intolerance or serious side effects, right? But in our experience, both on a trial and on commercial administration of this bispecific, we have now a good number of patients who had to stop their treatment for serious AEs, such as recurrent infections or GI toxicity from talquetamab. And thankfully, knock on wood, all of my patients are on extended hold are still in remission. And one of my patients is like over 2.5 years out, and she's still in remission without any additional treatment. And she had like a triple class refractory myeloma. So definitely these are paradigm shifting therapies, and it's possible that we need to explore more MRD guided and time limited bispecific therapy exposure. And the studies are ongoing. And one of the audience member also asked about giving these drugs earlier in the lines, because right now you have to fail certain lines of therapy for FDA package label, Shelton. So have you used this drug in a second line or earlier than that in your practice? And how did that go? I think we had a trial.
Yeah, only on trial, of course,
Yeah.
not on. I can't remember the specific trial, but yes. And I do think that they would respond, probably better, and because they won't have as many toxicities from prior therapies as well. They won't be as, that bone marrow is not going to be as beat up as whenever you see a patient that's had 7 or 8 lines of therapy before, these drugs were available. Their bone marrow is pretty beat up, and they have other side effects as well that just make it very difficult, especially, the carfilzomib induced cardio toxicities. I mean, you can, it all affects how well you're going to tolerate future therapies. So I think seeing them in, second line, that would be great for these patients. I did want to point out that even though these patients that we were talking about, we've had them on extended treatment holds, we are still monitoring their IgG levels. And a lot of times they're still getting IVIG and they're on these prophylactic medications because infection is just a huge risk for these. And it's very important to be mindful of that. And when they say that, they've got a cough, runny nose, even low-grade fever, in normal people, it wouldn't matter because they can fight it, but not these patients. So you have to be vigilant and intervene early and do further workup. So just wanted to.
That's an excellent point. I think I want to emphasize on that even after the therapy is on hold, their immune system does not recover for several months. And like Shelton mentioned, we do monitor their immunoglobulin and replace them and keep them on prophylactic antibiotics for a long period of time. And we are also seeing some unusual infection, which we typically don't expect in a myeloma patients, like CMV reactivation or HHV or HSV reactivation, almost like an allogeneic transplant or organ transplant recipient patient. So these patients' T cells are also impaired, along with the B cell dysfunction and hypogammaglobulinemia. And of course, you can give IVIG and that will fix the immunoglobulin problem, but the T cell weakness or paresis, we're not going to be able to fix it. And they do, if you check their CD4 count, they're usually lymphocytopenic quite a bit. So they do require closer monitoring. So we have 2 more questions before we wrap the session up, Shelton. So one attendee is asking about like our physician nurse practitioner RN model. So how the NPs are integrated with our practice, and how often the consultant or MDs actually see this patient once they are on a stable dose of bispecific antibodies.
Mm-hmm. Usually once they're on a stable dose and their disease is doing really well, the MDs typically see them like every 3-4 months, maybe. Of course, sooner if there's any issue, or if they're not responding. But I mean, the advanced practice providers, we pretty much keep them on a steady course, and we can easily monitor them, and so kind of take the load off the MDs to deal with the more complex patients that aren't tolerating treatment nearly as well.
Oh no, I think, Sheldon, you have way more complex patients than sometimes in my clinic. I remember seeing several with you. So thank you so much for helping out, because there's no way I could manage all of them on my own. So one audience member has asked about the neurotoxicity assessment on a patient who are getting outpatient bispecific therapy. So I can take this question. So the risk of CRS and neurotoxicity is actually only, in my experience, during the first 1 cycle of the treatment. Beyond that, there is very little concern for CRS or ICANS. So we don't actually monitor this patient for neurotoxicity once they are discharged after a step-up dosing. And once they are getting a weekly bispecific or biweekly infusions, they just come in the clinic, get lab checks done, see an NP or an MD, get their drug in an infusion center, and then they go home pretty much. We only counsel them about the monitor for infections and those kind of things, but we don't require patients or a caregiver to do the I scoring at that point. Now, if you are administering the step-up dosing, so cycle 1 in an outpatient basis, we did that in a handful of patients, and we model it after our outpatient CAR-T program. So basically, we don't rely on a family member to do the I-score. Actually, we do the virtual visit with our nurse practitioner, who is our CAR-T bispecific nurse practitioner, who kind of covers our after-hours service. And so we have a patient video call. Of course, we see them first thing in the morning. So around 8 or 9 o'clock, they come for in-person visit. Then around 4 or 5 p.m., we do a Zoom call and do the I-score and vitals and stuff. And then around 10 o'clock, 10 p.m., there is another virtual visit with our nocturnist nurse practitioner, and she does a full ICE assessment. Patients usually have the blood pressure cuff and a pulse ox and a thermometer, so we record the fresh set of vitals. And then there is another phone call just to touch base at 6 in the morning by the same nurse practitioner. And that's how we have kind of modeled our outpatient CAR program, where in 24-hour period, 4 times, there will be a touch point with the patient and a caregiver. But of course, the caregivers are also trained to do the I-score in case they need to. And they are trained to do the remote monitoring of the vitals and how to handle the portal and stuff. And so we ask them to do a questionnaire. This is like a multiple choice questionnaire, just to make sure that the caregiver understood what we're asking them to do, almost like a RIMS program. So that's one of our requirements for our outpatient CAR-T program. And with that safety measures in place, we are able to keep most of our outpatient out of the ICU, out of the emergency room, and kind of manage the toxicity on a timely manner. So, okay. Well, I don't think we have any more question at this point. Again, I want to thank you so much for preparing the presentation. For all the audience members, this will be archived on ISCH website for future viewing, and you can review it at your pace. Shelton has her email address at the end of her talk. So if you have any questions after reviewing the talk, feel free to reach out directly to her. It's not too hard to find my contact information also. So I'm also happy to help with any of your patients or any situation you're dealing with at home. And so again, we are almost at the time now. So there are a few more questions, but we will try to answer it via email. So please reach out to us because we are out of time now. So thank you again. Bye-bye.